So next speaker, Dr. Nikola Kolev, treatment of complex aortic aneurysms.
My slides, please. Dear colleagues, dear friends. I will start with saying thank you to the organizers and the organizing committee. I will speak about the physician-modified endografts for treatment of the complex aortic aneurysms, juxtarenal and pararenal. These are my disclosures. So, to be as most short as I can, I will go directly and practically guide. So, the classic indication, hostile proximal aortic neck, juxta or pararenal aneurysm, or ectopic visceral vessels, as you can see in the pictures. The technique that we are using, it means in the number of the endoprosthesis that we are using, we could do it physician-modified tube graft plus combination with bifurcation graft. In our experience, we're doing this only when the distance between the healthy zone and the last visceral vessel is more than 5 centimeters. Because the body of the bifurcated graft is 5 centimeters, then starting the bifurcation. When the part from the healthy zone to the last visceral vessel is under 5 centimeters, we are going directly with physician-modified bifurcation graft. And when we have ectopic vessels, we are using, in the most cases, either branch from the main part of the body or fenestrated iliac extension or iliac cuff. The graft preparation, you can see, we have a bunch of things that we can do. We can have fenestrated only, branch only. We can combine fenestrations and branches, and we can do whatever we want. For the branches, we are using self-expandable cover stands, and for the fenestration, marking with the coils. So, about the deploying technique. When we are working with two-component stent graft, we are using the tube graft with fenestrations or branches, and we are using the reduction wire technique. Or when we are working with only one main body, we are using the technique of partial deployment and cannulation of the visceral vessels via upper limb approaches. What are our results? For 1 year and 3 months, we've done 26 cases with average age of in between 73 plus minus 4 years, 24 males, 2 females. 19 of the patients were treated in my hospital, in the hospital that I'm working in, Military Medical Academy of Sofia, and 7 patients were treated out of my unit in peripheral hospitals in Bulgaria or in some other hospitals in Sofia. That means that we are sharing our knowledge. Control CTA was performed in 24 patients. 2 of the patients didn't have the chance to make control CT. We lost contact with them. They were from the deep province. And 7 of the cases were with concomitant oncological disease. There were 72 vessels included in the reconstructions. Our technical success is 70 cannulation successful And we had two patients one was with unsuccessful cannulation of one of the renal arteries because of the stent graft rotation. And the other one is actually the number 4 picture, where we had a collapse of the fenestration for the celiac trunk, but the patient has a pretty good collaterals from the gastroduodenal arteries, so there was no major ischemia. There were no cases of major visceral ischemia and no cases of acute post-interventional in-stent thrombosis registered. Endoleaks, we have 2 patients with endoleaks. In the 2 cases, that was a type 2 endoleak. First one is in the patient with 4 fenestrations, and the second one is in the patient with triple fenestrated endograft. You can see it a little bit later. I will talk about that case. So I will present some cases that we've done in our clinic. This is an emergency pararenal abdominal aortic aneurysm rupture. 68 years old male with abdominal pain, blood pressure, and you can see that I'm showing the native CT scan because in between the phases the patient had a hemorrhagic shock and we transferred it to the OR. So we did the measurements on the native CT. We did a triple fenestrated endograft, all of the assembly of maneuvers to cover the hemorrhagic shock, and we did a triple fenestration for the mesenteric and the 2 renal arteries. And of course, what did we miss with the native? We missed that the patient had an aneurysm of the internal iliac artery, which is finished. The results are pretty good, no endoleak, the patient is good, discharge, healthy. The second case is a patient with juxtarenal abdominal aortic aneurysm with pain, abdominal pain during the hypertensive crisis, and he didn't have a rupture, but it was a symptomatic aneurysm, so we decided to work it. We did also triple fenestration, but due to the chronic thrombosis of the left iliac axis, we did aorto-uniiliac reconstruction. You can see that we did it with bifurcated graft. In emergency cases when we don't have uniiliac that matches with the patient, we are deploying the bifurcated, and we are just ligating the contralateral branch. And on the control CT, everything is patent, and we did a femoro-femoral crossover just to have a good blood supply for the left lower limb. So this is another case, female patient, 70 years old, in other hospital than Military Medical Academy. We did this case with Professor Nikola Kolev. Rare case of symptomatic abdominal aortic aneurysm with dissection only into the abdominal parts of the aneurysm. You can see that in right, the internal iliac originates from the true lumen, and in the left from the false lumen. We did also triple fenestration graft for the mesenteric and the 2 renal arteries, and in the early period the patient was stabilized, and we noticed that we have a second type endoleak due to the endoleak from the right internal iliac artery. And about 1 month ago we did an IBD, also physician modified, for the right iliac to eliminate that type 2 endoleak. And you can see that in left we have also a dissection, but there is no endoleak into the aneurysm from the internal iliac artery. That's a good question maybe to discuss, because the dissection plan goes just below the external iliac artery, And I would like to ask, what is the best to do in this case when we have one patent iliac artery? Maybe to do embolization or to do the coverage, or maybe to try to cut the flap and to do another IBD. So, in conclusion, physician-modified endografts are viable options of treatment of the complex abdominal aortic aneurysm in aneurysms in high-risk patients, in emergent or elective cases when the custom-made devices are not available or we don't have time to wait to custom-made device to be produced. To achieve satisfactory outcomes, the procedure should be performed on selected patient by a dedicated team with sufficient experience and technical support. The most important part is to share our knowledge with our closest colleagues and friends, and the policy that we've built in our vascular societies, that the people who are working physician modified or are working routinely a complex aortic aneurysm, to go on place to help our colleagues in the province when they have such cases. So thank you for your attention.
Fantastic. Can I please just ask you to describe for us case number 1, how you looked after the patient with a ruptured aortic aneurysm while you are preparing? I mean, you've got this patient, he's ill, he's had a rupture, you can see it in the CT scan, and you've taken him to the operating room. You've presumably got some access. While you are creating your modified device, how are you controlling him? Do you have a balloon up just in case, but not deploying the balloon?
Of course.
Watching his condition. Well, how long does it take you? Because you've obviously got some good experience of 26 cases.
Yeah, they're a little bit more
and
now,
how long does it take? Describe, please, what you did.
For triple fenestrations, our routine is in military medical academies. When we had the CT, I'm doing the sizing. I have colleagues who are caring about the patient. They are placing a left axillary access and putting the compliant balloon in the descending aorta, and are collaborating with anesthesiologists. And I have another colleagues, they're waiting for me to give them the sizing report, which takes me no more than maybe in between 5 and 10 minutes. And to do such a triple fenestrated graft, to me personally, takes in between 30 and 35 minutes. If the patient is not stable, we are deploying the balloons. We have all of the axes. We can exclude literally the aneurysm, but in the first case that didn't happen because the anesthesiologists do the writing to have a normal blood pressure in the patient.
Fantastic.
Thank you. Other questions? No. Thank you.
Thank you. So I guess we'll go on.